Thank you for joining our Debbie Stream Foundation Curing Stomach Cancer webinar. Today's webinar is on caring for young patients with gastric cancer, successively younger generations with Dr. Jennifer Zikria. I'm Brittany Starks, Communications Coordinator for Debbie Stream Foundation, Curing Stomach Cancer, and I will be moderating today's webinar. Today's webinar is on caring for young patients with gastric cancer, successively younger generations with Dr. We would like to thank our sponsors, Genentech, Lilly Oncology, Merck, and Taiho Oncology for providing funding to make this webinar possible. You will be able to ask questions during this presentation. You can type your question into the questions section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. In addition, the recording of this webinar will be accessible on our website in the lecture library. First, I will share information about stomach cancer and Debbie Stream Foundation Curing Stomach Cancer. Then, we will hear a presentation on caring for young patients with gastric cancer, successively younger generations by Dr. Jennifer Zikria of Memorial Cancer Institute. The presentation will be followed by a question and answer session. In 2018, it was estimated that more than 26,000 Americans would be diagnosed with stomach cancer and more than 11,000 would die. Most patients diagnosed at stage 4 when the 5-year survival rate is only 5% and the incidence rates in younger populations has increased. Yet many know very little about this deadly disease and little research is being done. Pictured here is the founder of Debbie Stream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors for stomach cancer, and her symptoms were very vague. At the time, she was told that her chance of being alive in 5 years was only 4%. She endured harsh chemo regimens and targeted treatments and experienced many reoccurrences over 9.5 years. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50. She dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Debbie founded DDF in April of 2009. As an organization, we are a member of several advocacy coalitions, including the Deadliest Cancer Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie served for many years as a patient advocate on numerous committees and task forces. As an organization, DDF will continue her important work and legacy. Debbie Stream Foundation is dedicated to advancing funding for stomach cancer research, raising awareness about stomach cancer, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiestream.org. In a few short years, DDF has achieved many great milestones. We have 29 chapters across the U.S., as well as chapters in Canada, Germany, and events are ongoing around the country. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. We also have provided $1 million in research grants to date and advocate each year during our Stomach Cancer Capitol Hill Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program. We will be returning to Washington, D.C. next February to maintain funding for researchers. These efforts have resulted in nearly $18 million being awarded to stomach cancer researchers over 3 fiscal years. Please consider joining us February 2020 in Washington. More information can be found on our website under the heading Take Action. This is a current snapshot of our website's homepage with links to numerous resources. Here you can see some of the many events we have on the horizon. For more information about these and other events, please go to our website and click on Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8:30 a.m. to 5 p.m. Eastern Time. Also, on this slide are important phone numbers and email addresses you can use to contact our office and staff. We will now begin the presentation on caring for young patients with gastric cancer, Successively Younger Generations by Dr. Jennifer Zikria. Dr. Zikria is a medical oncologist at Memorial Cancer Institute in Hollywood, Florida, specializing in the treatment of gastrointestinal malignancies, including gastroesophageal, pancreatic, and colorectal cancers. Dr. Zikria also serves as an assistant professor at Florida International University and is a principal investigator on a number of pharmaceutical and cooperative group studies. We thank her for joining us today. And now, Dr. Zikria, I will turn the webinar over to you.
I want to thank Debbie's Dream for this opportunity to speak today on something that I think is very important to increase awareness. And I feel that Debbie's Dream really is the perfect place to do it, since Debbie herself was only 40 years old when she was diagnosed with this cancer. And she herself had no known risk factors. So I thank Debbie's Dream for bringing awareness to this topic so that we can make a change in research to hopefully change the results. If we can have the next slide. So just a word about gastric cancer. It's the fourth most common cancer, and it's the second leading cause of cancer-related death in the world. So it's a very deadly cancer today. Hopefully with more research we can change that. And gastric cancer mostly occurs in patients who are between 50 to 70 years old. But recently there's been a change in the incidence in patients who have gastric cancer. And this is why this webinar is very important today, to change the awareness of the age of patients that we see who are now developing gastric cancer. So if we can have the next slide. So I'm a medical oncologist, and I'm a medical oncologist that specializes in gastrointestinal cancers. And I initially actually started off doing pediatrics, and I switched over to adult medicine. And one of the things that you hear more as people are diagnosed at an older age with cancer is that it seems to be a more natural thing when you see it in people who are older. When you speak to a mother whose daughter is diagnosed with gastric cancer, one of the things they often say is that this doesn't seem natural. So since I've been in practice for the last few decades, I've noticed that patients are being diagnosed at younger and younger ages. And these are patients who may not even have a family history of gastric cancer. So for me, it was very important to look into how epidemiology is changing, how the patients that I'm seeing in my office are now significantly younger than what they were initially. When I first practiced, I saw that patients were between 50 and 70 years old with gastric cancer, but recently I've noticed that I'm having many more patients who are diagnosed in their 20s and 30s. And recently the data has actually supported this, that there is a study that recently found that your chances of being diagnosed with stomach cancer between the ages of 25 and 39 years old has increased 70% since 1977. So this is something that I think we really need to bring awareness to so that we can make a change, so that just like Debbie herself was only 40 years old when she was diagnosed, and see what makes this cancer different, especially in patients who haven't had risk factors that are traditionally seen in other cancers. If we could have the next slide. So these are patients that we knew were at risk, right? Patients who have a specific family history. And the NCCN clearly shows us who is at risk for genetic testing, and specifically, these were my guidelines when I first came into practice and other practices now, that any patient who was diagnosed with cancer before the age of 40. And I show this slide to talk about how many patients don't have a family history but are being diagnosed between these ages of 25 to 39. Can we have the next slide? So there is an emerging cancer trend that is happening in young patients. And what has happened is that there was a recent study that came out in one of the most prestigious medical journals called Lancet. And it came out in March 2019. And what it found was that patients are indeed being diagnosed at a younger and younger age. So it used to be your grandfather that was being diagnosed with gastric cancer, but now it's the mother of children that has been increasingly, the incidence has risen. And the reason why we care so much about this is that when we monitor cancer occurrence in young adults, which are adults less than 5 years old, I think it provides important information because it reflects the exposure that we may all have to carcinogenic factors. And when you look at young cancer trends, they serve as a sentinel to try to determine future disease burden in older adults, because those older adults are ones that you'd expect most cancer to be found in. So the thought is that there's exposures to carcinogens during early life that can affect our risk for developing cancer, and that it's these cumulative mutagenic changes that happen over time that build up and make people susceptible to developing cancer. So that's why we look at the trends in the incidence. Can we have the next slide, please? And what they have found is that obesity and cancer is often attributed to being one of the major risk factors for developing cancer. Now, we know that there's been an obesity epidemic over the past 40 years, and that younger generations worldwide, not just in the United States, are experiencing and are being exposed to obesity earlier, and that there's longer exposures to excess fat. And there's been numerous cancers that are well established to be associated with this excess body will initiate the endoscopy. It's been very well reported in other cancers, such as colorectal cancer, that the incidence in young patients is thought to reflect the obesity epidemic. And the reason why I wanted to have this talk is that this recent Lancet paper also found that gastric cancer also has an increased incidence they thought to reflect this obesity epidemic. If we can have the next slide. So this Lancet study examined age-specific incidence in the US. So they would look at patients who were between 30 years old and 90 years old. And they looked at the 30 most common cancers, and they specifically looked at the 12 obesity-related cancers, and they looked between 1995 and 2014. And what they found was that the incidence in young patients who were defined as less than 50 years old increased successively in younger and younger generations, and that for two cancers that was specifically seen. So in gastric non-cardiac cancer and also leukemia. So what I want to focus today is about gastric cancer. And the risk for developing an obesity-related cancer was thought to be in a stepwise manner where it happened successively younger and younger generations from their birth cohorts. So if we could look at the next slide, which looks at the data. So here is an example of a figure that was taken out of this Lancet article. And what I did was there were 12 obesity-related cancers. Specifically, I wanted to highlight gastric cancer. So you can see on the lower right-hand side, the gastric cancer cardia incidence. So that dotted line is the change that you see. And any increase from that dotted line is also represented by the shaded area, which is the net change with the standard deviation with the confidence interval. So what you really see is that that dotted vertical line is at 50 years old. So if you look at gastric cancer, you can see there are more and more people who are being diagnosed with gastric cancer who were born before the age of 50. Another way to look at it is demonstrated on the next slide. On this slide, what they did was they looked at the birth cohort. And what they did was they broke it down by the year that you were born. Again, that vertical line, just to really take it home so that everyone can compare it to your own birth date, is 1950. And you can see that after 1950, as you get farther from that, there's been an increasing incidence, more people diagnosed with gastric cancer since that time. And I find this to be so interesting because we consider ourselves healthier than ever, getting more access to medical care than ever, but yet people who are younger and younger are being diagnosed with cancer. And in fact, what they found was that your likelihood of being diagnosed with stomach cancer between 25 and 39 years old, it's increased 70% since 1977. So I think that really takes it home as you compare it to our own birth dates. Can we have the next slide? So these are
our recorded webinars. Please visit our
in the United States. And the risk for developing cancer has increased in younger adults for 6 out of those 12 obesity-related cancers. But most worrisome is that there's a steeper increase in progressively younger ages and successively younger generations born since 1950. And some are thinking that this is due to a rise in obesity. But there are other causes that have been suggested as well. And that's what I think is most important, is that there really needs to be more research done, because obesity, I don't think, explains everything, since a lot of the patients that I'm seeing in clinic are not obese. The gastric non-cardia incidence was thought to be due to many different factors, and some of them that were suggested was the prevalence of an autoimmune or an atrophic gastritis that was related to either exposures to antibiotics or acid-suppressing drugs such as Protonix and Pepcid. So can we have the next slide, please? So what I set out to do was to review the research in gastric cancer patients and how they did. So we know it's happening younger and younger ages, but how do these young people do? And what I found was that the definition of young has really decreased in the medical research. When you look at older research, the young was defined as people under the age of 70. Now, the research is defining young as people younger than 45 years old. And I think, again, that really takes home the successive younger generation, thinking about this was my grandmother, now this is a mother that's having this cancer. And what they found in this article that was by Rona in Journal of Surgical Oncology, also one of the most prestigious surgical journals that was published in 2017, is that there is a higher incidence of late disease, early and later stages, stage 3 and stage 4 diagnosis in patients when you compare them to being less than 45 years old and more than 45 years old. In fact, patients who are younger, who are less than 45 years old, 86% of them were diagnosed with the late stage. And if you compare that to younger or people older than 45, 57% of them were diagnosed. So young patients are coming in and being diagnosed at a later stage. The other thing that was very relevant was that there were poor prognostic features to these young patients. Specifically, the type of cell that was being seen on pathology was more likely to be a poorly differentiated cell, where 96% of them had that compared to 74%, or a signet cell type of cell, which was 88%, which is 32%. a signet cell is one of the most aggressive cells. So the pathology of young patients had a more aggressive cancer that was causing it. When you think about cancer, you think about a cell growing. So the faster a cell grows, the worse, the more poorly differentiated it looks under a microscope. And that's what the pathologists are seeing when they look at gastric cancer in young patients. And these late stages and the worst prognostic features with the pathology translates into a worse overall survival. So, you know, it's just devastating to see these 3-year survival in these young patients. And this study found that if you were diagnosed early, you still had good hope. You had 87% of patients that were still alive. But the later and later stages you go, you know, it translated to a worse survival. Whereas if you had diagnosed with stage 3 cancer, the survival was 32%, and at stage 4 it was only 7% for these young patients. So when you see these numbers like this, it's very difficult to see it, but this is what the study has demonstrated. And that if you look at the median survival for how long patients were living, it was significantly lower in young patients, where if, you know, it was only 11 months in younger patients, whereas older patients, more than 45, had 41 months. And this was dependent on the stage. So, you know, what they also found was that the young patients and the old patients, they were older patients, I can say. I can't even believe I'm saying old patients when you're more than 45. But this study looked at patients who are older than 45, and they were receiving the same treatments with the chemotherapy, the surgery, the radiation, but there was no added benefit to adding surgical intervention to patients who had like a late stage 4 malignancy. So, you know, sometimes you think you're young, let's do the most we can to treat, let's be as aggressive, but in fact, if it was a late stage, there was no added benefit to offering surgery to these late stage patients even when they were younger. If we could do the next slide. And so this really highlights what the definition of young age is. You know, there's a joke, especially as I get older and older, that age is dependent on how old my birth date is, right? And so I think it's very important that to define what old is. And so gastric cancer from the SEER data, which is the surveillance epidemiology and end results, from 1973 to 2014, they diagnosed close to 80,000 patients who are more than 18 years old. And what they did is they broke it down into young age, middle age, elderly age, and extremely elderly age. So these kind of breakdowns in the definition of age really help us determine if there's something different epidemiologically going on in each of the age groups that present. And this was defined also in 2019. That had this very important topic called more attention should be paid to adult gastric cancer patients younger than 35 years old. And I think that is really the highlight of this talk, that there needs to be more attention paid specifically to what is causing these late stages, highly aggressive malignancy in patients who are less than 35 years old. And perhaps it's not just obesity that's going on here. If we could have the next slide. So another study, so this is the same one that was talking about more attention to young patients. What they saw was that young patients who were less than 35 years old had the worst prognosis compared to all other groups, including patients who were elderly, who were more than 74 years old. So if you look at this slide, what they saw was that the survival of patients less than 35 years old was 12 months versus 15 months in someone who is middle-aged, or 16 months in someone who is elderly. And that the location of the tumor, the ethnicity, the tumor size, whether or not they had surgery, or the tumor size, metastasis to the lymph nodes, they were all independent prognostic factors that were seen in multivariate analysis. So if we can have the next slide, please. So the question is, why do young patients do worse? And what can we do to change it? And there's definitely a change happening in epidemiology now. And perhaps young patients do worse because they have different clinical features and their tumor behaves differently, more aggressively. So the literature tried to ask this question, why do young patients do worse? And what I found is reviewing the research was that there was a female predominance, that the location of young patients are often in the upper third, or the cardia of the stomach, that there was more undifferentiated and diffuse histology. Specifically, this diffuse gastric type was associated sometimes with an E-cadherin dysregulation. And this E-cadherin gene is called a CDH1, and these mutations are more common in young patients with gastric cancer. And the thought was that maybe genetic factors can play some role in developing gastric cancer in patients with young age based on this CDH1 gene. The other issue is that patients who are young often present with less alarming symptoms that are just not being followed out. They may be having abdominal pain, but it's not being referred to gastroscopy. And I think that's another very important point of this webinar, is that for the patients treating them, especially the primary care physicians out there or the gastroenterologist, please evaluate young patients' complaints thoroughly, because young patients are not being referred to gastroscopy or endoscopy as much as older patients are. And because of this, there's advanced stage 4 at diagnosis, and we're losing our chance for a curative resection. Can we have the next slide, please? So as an oncologist, I also find that I want to know how best to take care of my patient, not just from a scientific medical perspective, but really how to help the overall mind, body of the patient so that they have their best quality of life. And, when you care for patients with young cancer, and this specifically was looked at by Sun and also in 2019, young patients have a fear of cancer recurrence, even more anxiety than would be expected in older patients, and even more depression than patients who are older. And in multivariate analysis, what they found was that the patients who had the most trouble psychologically with anxiety and depression and fear of cancer were patients who were alone in it, patients who were single, having a pessimistic outlook on things, or if they just had a lot going on, if they had more concurrent life events, or their own physical being, if they had a lot of physical comorbidities. These are factors that make young patients have even more difficulty with their diagnosis. And there's a real need to have age-appropriate and flexible psychosocial interventions to help these patients and provide care beyond just addressing these clinical needs. And the other thing that's very important that I think we need to think about is for early stage cancers, stage 1 and stage 2, thinking about the effect of chemotherapy on their reproduction. And I think that gastric cancer needs to take a page out of what we do in breast cancer, where patients are referred to reproductive fertility experts in young stage cancers who have hope. So in conclusion, I really want to thank the listeners in Debbie's stream and the sponsors of this. What I tried to do was increase the awareness that's needed for young people who have gastric cancer, and really highlight that there is something different happening in epidemiology, where the incidence in young patients with gastric noncardia is being found increasingly in successively younger generations. And really highlight that currently patients who are young with gastric cancer have a worse prognosis because they're diagnosed at a later stage, or they have a worse pathology, but that it is so important, and that the hope really should lie in early detection for these gastric cancers and finding these diagnoses earlier, and clinical research that can try to determine why these patients have worse pathology and what can be done, and how the role now of targeted treatment and different mutations are going to fit into that. So the last slide is my acknowledgement page. if we can see that last slide, Brittany. And so I just really wanted to finish with, again, thanking Debbie's Dream for this webinar and the sponsors. I wanted to thank my patients who have allowed me to take care of them and to become part of their families, and thank my own family for helping me through this. I want to thank and acknowledge our outstanding Memorial Healthcare team here. We really try to make it a family here, and I want to thank Marnique and Josie, our nurse practitioner, Valencia, and Glenda for establishing this, and really thank the team of multidisciplinary efforts that are available here, including our gastric cancer specialized surgeons, Dr. Dan and Dr. Piderecki. I wanted to thank our expert thoracic surgeons who are capable of non-invasive thoracic surgery with Dr. Block and Dr. Tarazi, our interventional gastroenterologist, Dr. Ribeiro, our amazing interventional radiology team and radiation oncology, and of course all the other efforts that go into it, including palliative care, our research department that's constantly trying to get new trials here, our nutrition, our social workers. So thank you all for listening, and hopefully more research is needed to try to make a change so that when we look at these incidences and survival later on, we can see that, that young patients can do better. Thank you.
Thank you so much for sharing with us today, Dr. Zikria. I know that this is an exciting time in research, and it generates a lot of interest and questions from patients and their loved ones. So we've received some questions during your presentation, so I would like to ask a few in our remaining time. Okay, so one of the questions we have so far is, what type of diet would you recommend to help prevent stomach cancer or for stomach cancer survivors?
Yeah, I think this is an excellent question. When you look at the research in gastric cancer in young patients, what you really see is that it's obesity trend. So there seems to be a cumulative effect of obesity, and even when it occurs very young. And so that patients are, even in their younger age, they're having higher body fat, even at young age. And that if we can prevent obesity in children and adolescents and young adults, that we can make an effect so that this cumulative effect of obesity does not, continue to cause these carcinogens in patients. So I think that what we need is a healthy, well-balanced diet to try to prevent obesity. But again, I don't think that explains everything. In fact, when you looked at the non-cardia patients, there were two other factors that were suggested. And one was the exposure to antibiotics, or the constant exposure to proton suppressing or acid suppressing medications. So, I think that a well-balanced diet with a good healthy weight at least will try to help the obesity portion of this. But again, I think there needs to be more research done, because in my clinical setting, I don't find that a lot of these patients are obese. And in fact, some of these people are, that have this cancer are young, very fit, and don't have any risk factors. So clearly there needs to be more research done with it. So we all do the best we can with eating right, because that's the right thing to do. But I think there's more going on.
Okay, thank you so much. Next question, is there an increase in gastric cancer specific to ethnic groups?
Yeah, so it's a very, very good question. In fact, you can see that with gastric cancer, there's been a higher incidence recently in specific ethnic groups. It's well cited in the research about exposure, like in Japan, where they actually have surveillance programs for gastric cancer. South America as well, because of the risk factor for Helicobacter pylori and the bacteria that causes gastric cancer. And so those are two specific groups that have been looked at. But as we know, gastric cancer happens in all ethnicities.
We have another question that rolled in. It says, what are you doing for screening detection?
Yeah, so that's actually one of the things I really wanted to stress on this trial, especially as young patient symptoms are often younger or less vague, and so it's very important. The screening for an endoscopy, like certain groups have been doing endoscopy surveillance for patients in Japan who are in high risk, but here in the United States, unless you had a known genetic mutation, the genetic screening, or based on genetic screening, endoscopy is recommended. So if we know that you have a risk factor for developing gastric cancer, then annual endoscopy is recommended. But if you don't have a known genetic mutation, then the screening really is based on symptoms, and it's the symptom that will initiate the endoscopy.
Thank you so much, Dr. Zikria. Unfortunately, we're out of time for more questions today. Dr. Zikria, thank you for joining us and sharing your expertise.
Thank you so much to the listeners and Debbie's Dreams and our sponsors. And thanks again to Genentech, Lilly, Oncology, and Mark.
Thank you again to our sponsors, Genentech, Lilly Oncology, Merck, and Taiho, for making this webinar possible. As a reminder, please check out our website and check your calendars to join us for an event near you. Thank you to all of our listeners today. This concludes today's presentation. Please be on the lookout for information about our upcoming webinars this year. To view any of our recorded webinars, please visit our lecture library and search by the topic you are interested in. We would also love to hear your feedback, questions, and thoughts, so please be sure to take the survey that will be sent to you once this webinar concludes. For any questions or suggested topics for future webinars, send your comments to patient.resource@debbiesdream.org. And for more information, visit www.debbiesdream.org. This concludes today's presentation. Thanks so much for tuning in.